1 and you can start, sir.
Good
evening, everyone. Is Dr. Kajal Prasad Ghosh? Are you? Yeah, Kajalda, please start the meeting. We are live now.
Hello.
Please.
Yes,
Please
we can
carry
hear
on,
you.
sir. Please carry on.
Yes.
Yes.
Please.
Dr.
Dr. Kajal Prasad Ghosh, President of OSWB, will be starting the meeting. Kajalda, if you are ready, please.
Yes, I am ready.
Yeah.
I am ready. Can you hear me? Hello?
Yes, yes, we can hear you.
Okay, okay. So, hello? Hello,
Yeah, please.
welcome to this, welcome to this webinar. So, you see, we are now passing through a very bad situation, a grave situation. And I should say, that, well, the history tells us the greatest disasters are not that of nature, but of human mismanagement. Massive loss of lives during famines, floods, and epidemics, even in the past centuries, was as much as a result of political apathy and social inequalities as that of natural disasters. Public health and technology advanced exponentially in the 20th century, and today we live in the world where medical research and technological infrastructures have reached tremendous heights, with the technology and medicines today to give oxygen support, life support, and medical care for those experiencing severe symptoms of corona. What we do not have is the political will and the respect for human lives. And that is the greatest tragedy of all. When the corona hit us COVID-19 hit us in 2020, we did not have sufficient infrastructure to deal with the massive number of cases and requirement for medical care and oxygen. In fact, the whole world as a whole was unprepared for the scale of epidemic, and India was no exception. But unfortunately, after the first episode, the whole world took lesson to prepare themselves for the second episodes. But when the first time round, we were caught unprepared. The fact that this time round two, we are unprepared cannot be forgiven. The scale of this tragedy could have been averted had our government responded in time and invested in saving lives. Thank you. Hello?
Go to unmute
Hello?
yourself.
Go to unmute. Sugata, you have to unmute yourself.
Yes. Good evening. Good evening, everyone. Thank you, Dr. Ghosh, for your speech. So welcome to this webinar. Now, as you all know, like last year, OSWB has decided in this difficult time not to go for any ophthalmic academic meet, but to start with COVID and try to be by the side of our colleagues. And one of the important way to be with the colleagues is to learn for ourselves how to save ourselves, how to safely sail through this pandemic. So we have arranged this webinar. Today we have Dr. Pushpita Sahu and Dr. Kajal Prasad Ghosh as the chairperson. Just give me a few seconds. I'll share my slides. Am I visible?
Not yet.
Just 1 second. Can't even see myself. So today's meeting is being sponsored by Ocularis Mankind. I thank them for coming forward, and also we need to congratulate them because they have just announced 100 crores of donation for the COVID matters for the doctors who are losing their life. So I would like to thank them for coming forward with this noble work. Is my screen visible now?
Yeah,
Yeah,
can you make it a
Dr.
slideshow?
Yes.
Dr. Sugata, I
Yes.
think there are some response coming that they're not able to join in YouTube live. Mr. Aditya, can you just look
give
into
me
it?
1 second. Let me go to the slideshow first. They can click the link and join the link, but I'll sort it out in a second. About the YouTube. I'll speak and sort it out. Okay, so today as panelists, we have Dr. Abhijit Ghosh, Dr. Ashim Kumar Ghosh, Dr. Ratish Chandra Paul, Dr. Rajesh Majumdar Choudhury, Dr. Rudra Ghosh, Dr. Shondip Mitro, Dr. Saurav Sinha, and Dr. Suchanda Sir. So thank you all for giving your time on this Sunday evening. And also we have co-moderator or discussions, Dr. Aniruddha Maiti, Dr. Siddhartha Ghosh, Dr. Rupak Kanti Bishwas, Dr. Ayan Mahanto, and Dr. Devashish Das. Thank you again for giving your valuable time, and hopefully you will carry forward the meeting and make it very lively. And beside them, we have Dr. Anjan Mukherjee, Dr. Suman Kanungo, Dr. Shyamashis Bandyopadhyay, Dr. Shivabrata Banerjee, and Mr. Rupak Barua as the speakers. They have given their valuable time as well. Thank you. Thank you for joining this meeting. And now I'll play a small video of Mankind Ocularis, and then I will request Dr. Aniruddha Maiti to take over.
The most common include cataract, glaucoma, and retinal disorders. 80% of these have a chance to get cured. But due to limited access to eye care facilities and medication, over 8 million have lost their eyesight completely. And millions of others suffer with pain, agony, and helplessness. It's sad to see so many people in our country are losing their vision. By taking small steps together, we can save their light. To create a better India, we must think coherently and create a roadmap where we cover every nook and corner of the country and enable easy access to medical treatment and affordable medication. It gives us immense pride to forefront a fundamental challenge and come together as a strong community to bring light to millions of lives. Our commitment towards quality, affordability, and availability remains at our core. Taking this forward, Mankind would like to join hands with you to reach out to millions of those who need our hand to brighten their world. Introducing Ocularis Mankind, our dedicated division for ophthalmology, focused towards creating efficient and affordable eye care medication across India. An eye for India.
Thank you very much. I would request Dr. Aniruddha Maiti to invite Dr. Anjan Mukherjee and introduce Dr. Mukherjee for his speech.
550 million people
Sorry.
suffer from visual disorder. The most common include cataract, glaucoma, and retinal disorders.
Can you switch off the audio?
Yes, I am trying to. Why is it?
But due to limited access to
mute
eye
us,
care
huh?
facilities and medication,
Is it?
Thank you, Sugata. It's my pleasure to introduce our dear friend, Dr. Anjan Mukherjee. Dr. Anjan did his MD from the prestigious All India Institute of Medical Science. After following his MD, he joined as a consultant microbiologist and in charge lab services in Shankar Hospital of Kolkata. He was there for 2013 to 2017. At the same time, he was a part-time consultant microbiologist at Figure Institute of Cardiac Sciences. Following that, in 2018 to 19, he was attached to many places like Calcutta Heart Clinic and Bellevue Hospital. Presently, he is attached to Apollo Gleneagles Hospital as consultant microbiologist, and he is also an NABH assessor. Welcome, Anjan, to this webinar, and thanks for sparing this Sunday evening with us. And I know we all are passing through a very difficult times, and we like to hear from you. Welcome, Anjan. Are you there?
Hello, yeah, welcome. Good evening to all of you. So I hope you are all taking good care of yourselves and trying to be as safe as possible. So the basic thing that I would like to discuss with you people is there is a lot of discussion regarding the second wave through which we are going through right now, and the role of the virus in particular, and the role of the microbiological diagnosis in the virus.
Right.
So,
Anjan, can we discuss through some questions? There's some.
Yeah. That would be
I
great.
think we are all aware of the second wave of COVID. So, is this the second wave due to a new strain of COVID virus?
Well, I would say the new strain will come very low in the list of reasons. The new strain maybe sixth or seventh reason for this second wave or the calamity. The primary reasons being the lack of adherence to protocols and somewhat casual approach, which includes the casual approach of common men as well as the government, the administration, the large-scale gatherings, which include the political, social, as well as religious gatherings, which has led to the present situation. Now, if you analyze the science of virology, mutation is something which is inherent and inevitable. We cannot stop an RNA virus from mutating. The more it replicates, that is, the more it passes through one host to the other, the more it will mutate. So emergence of mutants is likely and inevitable to happen. In a way, I would say because this RNA virus, this COVID SARS-CoV-2 RNA virus is not having a segmented genome. That is why the rate of mutation is somewhat, in fact, lower than some other viruses which are notorious for mutations, like the influenza virus. So I think we should not find a scapegoat in the poor virus. Rather, we should point our fingers to appropriate places in order to address these issues.
True. So, regarding this new strain, what is the implication? Is it this mutation for the good or bad? Because there is a concept that when the viral infection goes, there is several mutation, and then the virus goes. So, what is the implication of this mutation?
This is actually a bit long story. Let me try and shorten it as much as possible. Taking the cue from your words, if you look at it from the viral evolution perspective, a virus, in order to be a successful parasite, will not kill its host. Okay, that is not the target of the virus. The basic target of the virus would be to successfully complete its replication cycle. So, as an evolutionary advantage to the virus, the more transmissible it is and less lethal it is, the more advantageous it is for the virus to replicate and to propagate its cycles. So as a result, the strains of virus with mutations which will help the virus in propagating, that is high transmissibility and ability to evade the immune system of the host, will be chosen over viruses which are more lethal. So that is exactly what is happening. So it is not like something very strange is happening. I think it is an inevitable thing that's happening, and it has caught us off guard is the protocols.
Okay. There is a concept that this RT-PCR, is it true that the RT-PCR is picking up this new strains? Because many cases, what is happening, they are symptomatically COVID, but the RT-PCR is coming out to be negative. Is it also due
Right.
to the new strain, or the virus has changed its character? Because this is
See,
common. We are having
see,
negative in COVID suspect. Later on, after 48 hours, it's coming out to be positive.
these are actually two different issues. One is that it is well known now that RT-PCR, even in the best of circumstances, has a sensitivity of around 65 to 70%. In short, 1 out of 3 cases are likely to be missed by RT-PCR. Add to it, there are various factors which includes the appropriateness of the sample collection, transport, processing, everything. So RT-PCR inherently will have a degree of false negatives. It has to do with mutations, because last time when the original Wuhan strain was the only strain that was suffering, we also had this problem. These type of issues used to come regularly last year also. So it is the same thing that is happening this year, nothing new. So the issue of false negative is something that will remain. So it is not related to the mutation that is being reported. Now, regarding the mutation and its role in diagnostics, I would like to clarify this thing a little bit. For mutation, picking up mutation, I'm sure it has been reported in several places. We go through an elaborate process of sequencing of the RNA for the concerned virus. But in general, the entire virus is never sequenced. So a portion of the virus is chosen for sequencing. In this case, most of the strains, most of the strains, mutants, variants, whatever are being reported, is being reported based on sequencing of the S gene, that is which codes for the spike protein. Spike protein, by the way, is that particular protein which helps the virus to attach to the human ACE2 receptors. In short, it helps in the attacking of the virus. It is the mode of adhesion of the virus to the human cell. So this is one sequence which is prone to variation. As against the targets which are chosen are nucleocapsid or the RNA encoding genes which are embedded further within the genome of the virus. So these are two different targets, and mostly for most commercial PCR systems, multiple targets are chosen, not one single target. So even if one is missed, the other will pick up. So it is not likely that mutation at a few sites in a particular piece of the genome will lead to it missing RT-PCR surveillance. And that is not happening. We are having very high percentage positivity every day in our labs. So there is no way we are missing cases because of the mutation. Of course, RT-PCR has its limitations, but it is not due to the mutation.
So there is no difference between this last time and this time, right?
from a point of view of RT-PCR diagnostics, no.
And there was a concept like if you are symptomatic, it is always better to test it on the 3rd day or 4th day. Is it true? Or whenever you have symptoms, you can do the RT-PCR test.
See, again, we can look at it at point two perspectives. The reason why we say 3rd or 4th day is because at that point of time, we expect the viral load to be highest. Okay, so that is why that particular day is chosen. Now, if somebody is very severely symptomatic, as a corollary, we can assume that the viral load will be high from the very beginning. So there is no reason why we should delay diagnostics. Okay, because delaying diagnostics will lead to two problems. One is it will spread amidst the close contacts. The person may roam around. The person may stay in a house crowded with other family members. So it will create a lot of problems. And secondly, it will lead to what you call the deterioration in the clinical condition of the patient. So that doesn't help. So as soon as you are symptomatic, it is best you get the test done. And
if the first test becomes negative, so what is the recommendation? But the clinical suspicion is there. So what is the recommendation?
If the clinical suspicion is there, you should always repeat it after 48 to 72 hours.
Okay. Lastly, I would ask, what is the situation of the labs? Because I've been hearing that nowadays the reports has been delayed grossly. So can you just update what is the situation in the lab and the test? Because we know there is a lot of sample load every day.
See, it is understandable that like in all other places in the hospital and the healthcare sector, the labs are also under considerable stress. We are trying our level best to be updated. That is, we are trying to release the reports the same day, if not at least the next day, first half. So I hope we can manage to keep up with that schedule. Okay, so far, at least in our lab, we have succeeded. Hope to maintain that thing in future also.
Is there any questions from our panelist or chairperson? Otherwise, we'll move on to the next talk.
I have a question.
Yes, sir.
Does the vaccine in any way change the character of the virus?
The vaccine directly no, but indirectly it will prevent the virus from mutating further, because the more the population is vaccinated, the less number of susceptible hosts the virus will get. As a result, virus replication cycles will reduce in number, and the less the number of replications of the virus, the less chance the virus will mutate. So in a way, if we ramp up the vaccination, that is, we vaccinate more number of people at a lesser time, we will actually prevent the virus from replicating further and prevent emergence of mutants. So that way it does.
I would like to ask a question, if I'm permitted.
Yes, ma'am.
Okay. What I want to know is, we are hearing that you are getting infected with COVID again after vaccination. Now, in a country like ours, where the people are not tested prior to giving the vaccination, where they are asymptomatic COVID carriers or not, this is what is your opinion? I mean, how many people, what is the percentage of people getting reinfected again after 2 doses of vaccination? It is very difficult, I think, to actually come to a conclusion in India, because we are not testing everybody before giving the vaccination to know that they have been COVID-free. Am I wrong?
Madam, can I respond? I'm Dr. Kanungo from ICMR. Can I respond?
Yes, please do.
So I have a slide. I'll show you exactly pointing towards this. Till now, this is a slide. This is a data that we presented to PMO, and that which has been it has been released official official data. I can show you today. I have the slide.
I think the
Where
next topic is on vaccination, so we can move
I,
on.
I'll respond to that. I'll respond to that.
Siddhartha,
Aniruddha,
yes, sir.
Aniruddha,
Yes, sir.
Aniruddha, I have a question.
Okay.
Yes, please. Yeah.
I mean, how long the immunity lasts?
Sir, again, I think that will be answered after the next
I
talk.
think the next
by Dr.
topic is vaccination, and that we can have the discussion following that.
Yes.
Siddhartha.
I
if
want to
there
ask
is-
a question. Sorry,
Yeah.
are the speakers going to give some speech, and then are we going to ask questions and answers, or is it only a question and answer session?
We have left it to the speakers to decide whether they're giving a slideshow or whether they will take questions directly. So let's see.
I see.
Okay, so may I now invite Dr. Siddhartha Ghosh, Senior Consultant at Apollo Hospital and also at GD Hospitals, to welcome and introduce Dr. Suman Kanungo and carry on with the questions.
Yeah, good evening. Thank you, Sugato. Let me introduce Dr. Suman Kanungo. Dr. Suman Kanungo is the Deputy Director, Scientist team working in ICMR, National Institute of Cholera and Enteric Diseases, Kolkata. Being an epidemiologist and public health specialist, he has been working on disease burden estimation and has been involved in evaluation of vaccine efficacy and effectiveness in endemic settings for more than 15 years. He has conducted several national and international collaborative projects. He is Fogarty Fellow, received NIH ATRP Fogarty Fellowship for training in epidemiology in University of California, Los Angeles, USA. He received several international grants and awards and is a member of the National Task Force and Rapid Response Team for COVID in ICMR. He has published more than 70 papers and book chapters in national and international peer-reviewed high-impact journals. His current interest in research is disease burden estimation and randomized trials, especially on enteric vaccines like cholera, rotavirus, typhoid, dengue, and influenza. He is a life member of Indian Science Congress Association, Indian Medical Association, and Indian Public Health Association. He is also a reviewer of several national and international journals as well. Let us welcome Dr. Suman Kanungo for his presentation, please.
Thank you, sir, for not so much true things about me. I work I do clinical epidemiology in Indian Council of Medical Research for the last 20 years. So I have a short presentation. So my take is that let me present it. I will not go through each and every slide. I will pick up some of the points and then we can directly go to the discussion. What do you think, sir?
Yes, that will be very good. I think, please, you can share your screen for the slide.
Right, sir. Right, sir. So is it visible?
Yes, it's visible.
So I'm going directly, I'm not going to the taxonomy and all that. Now we have almost, with 1 crore 35,000, 47, more than 1.5 crore vaccination. Yet with CFR 1.15, 219 countries are affected and we are in the second wave. So if we look at the second wave, this is typical of influenza group's second wave, which occurs way back in 1920 with Spanish flu. It occurred like that and this is the current scenario. What we usually see, there is a steep rise, and as we have done modeling, which have not come out right now, there will be a steep fall. if the infection rate is like that and force of infection is like that. And I'm taking the cue from Dr. Mukherjee, which he started with. I mean, this is a typical virus, if I'm allowed to say, because it has an R naught of around 3, which is, incubation period on 5 to 7 days. So if we consider the herd protection 1 minus 1 by R naught, it is around 67 to 68% it needs to be infected to get an herd protection. So this is a typical virus to become a pandemic one, like it has got low CFR, big incubation period, and high R naught. R naught means you people all know that now, that it can, in how many people it can infect on from primary infection. So this is the current scenario of India right now. But if we consider this West Bengal, which is in the medium zone, affecting around 4,000 daily cases, with high cases obviously in the western part in Karnataka, Maharashtra, and Telangana. This is the current scenario right now. So this is the ICMR official data that we have published. That during this one blue one is basically it's current data, current second wave, we can call it 2021 data, and this one or orange one is the 2020, or say you can say the first wave data. If you look at the age wise cases, it is more or less evenly distributed. Now we are coming to a myth that it is affecting more and more younger population. It is and death, it is little bit higher side, but it is, if we go by epidemiology and statistics, it is not statistically significant till now. If we look at the younger age group, in 2000, younger age group was a little bit higher in 2020, but in 10 to 20 it is higher in 2021. But the difference is so small that it is not the right time to say that this younger population is much more affected. It is death wise also, there is 2020 and 2021 deaths age wise is not that significantly different. So now coming to the platform used for COVID-19 candidate vaccine development, because I will mostly talking on the vaccine, currently available vaccines, its trials and its uses. Mostly these are protein subunits. These are protein subunit. Live attenuated virus is a little bit risky, it's a bit late. Live attenuated is less, and viral vector non-replicating is more and more coming into play. Some are in around 20 candidate vaccines are in preclinical phase, and clinical is around 8. For the protein subunit vaccines, around 60 are in preclinical stage. This is the global data I'm talking about. In India, the 3 vaccines that has been approved by the CDSCO and subject expert committee, I'm coming to that later. So this is the scenario. Why I'm talking about that? When we talk about vaccine development, we all know that it goes through 4 phases. From phase 1, pharmacokinetic dynamics, to effectiveness and post-marketing surveillance. And as routinely, we have preclinical studies, phase 1, phase 2, phase 3, and phase 4. But this is an absolutely abnormal, extraordinary situation. We need to have accelerated development for COVID-19. So what we did, we have preclinical phase 1, phase 2, phase 2, all squeezed into one. Simultaneously, sequentially we did it. Normal vaccine developed performance each step in sequence, but we did not here. We accelerated COVID-19 vaccine development. States are done in parallel. This is the first time in modern science. Early back post. Post-COVID, this is the order which we followed. All usually safety and efficacy monitoring mechanisms remain in place. It does not mean that the safety, we are floundering with the norms. It is there, such as adverse event surveillance, safety data monitoring, and long-term follow-up. These are all there. And phase 4 post-marketing surveillance, we are already started. ICMR has already started. I'll show you the data along. So what we usually takes around 10 years, what we have done that pandemic, as I said, by doing different steps parallelly, adverse event, safety data, long-term follow-up, all are done sequentially. So this is the January data. Right now, I do have March data. There are 233 candidate vaccines, 170 vaccines being evaluated in preclinical, 63 clinical phases of testing one. This is one. 63 are in clinical phases. Majority were in, and mostly are in phase one is around 20, phase one or two, 15, and 15 are in phase two, three trials right now. So what are the vaccines so far? We have RNA-based vaccine produced by Pfizer, BioNTech, Pfizer. These are in 90 showing an efficacy of 95% in phase 3, approval in 35 countries. In India, it is not there. Moderna is the same thing in 15 countries. This is also an RNA vaccines. It shows around 94% efficacy. COVID, this is COVID-19 vaccine. This is the Covishield. There's much talked about vaccine. This is a vector, adenovirus as a vector. This is around 70%, 16 countries, including India. Sputnik recently, it shows an efficacy in 14 countries, 91% for. This is a non-replicating two adenovirus vectors, Gamaleya Research Institute. It shows this one. And last but not the least is the indigenous one, inactive whole virion inactivated vaccine developed by Bharat Biotech ICMR. This is ongoing phase 3 trial. I can share you the unofficially it's 78% protection interim analysis is 78% protection, but this is not to be quoted right now. We are writing the, we are doing the final analysis. The trial has it's ongoing safety follow-up, and this is the post-vaccination breakthrough infection. Pushpanda ma'am, are you there? This is the data that you wanted to have a look, right? This is
that was one of the questions. Yes.
Yeah. See, if you consider, if you go by the definition of breakthrough infection, it is to be after full. It can be either partially vaccinated or fully vaccinated. Partially vaccinated means after positive after first dose. That is both the vaccines which are Sputnik V is not yet been introduced, but Covaxin and Covishield more or less comparable, 0.4% and 0.2% after first dose. After second dose is again 0.4% and 0.3%. But this data is very early, and the number of received first dose is more or less similar, but this is only 2 months data. Until and unless we have a full year data, this is too early to comment what is the rate of breakthrough infection. So these three vaccines are there. Sorry, it's V. It's not VI. It should be V. There's a mistake. So this one is phase 2, phase 3. This is a big trial. So why I'm saying that people have the myth that these people are made guinea pigs. Trials are not being done. Safety follow-up had not been done. Like efficacy was not being tested. Adverse events were not monitored. It was rather hurriedly it was done. It was not that. It was not that. As I explained to you, all things preclinical, clinical, safety, long-term follow-up has all been initiated parallelly, and huge number of subjects has been taken into consideration, and it shows has already been approved in several countries, showing that it's around more than 70% protection, and it has been given emergency use approval. Currently, an inhaled version of the vaccine is being tested, a small trial of 30 people, not here. And another trial is ongoing, combining both Covishield and Covaxin. Vector vaccine as virion vaccine is planned. So 70.4, if you look at the CI is pretty internal validation is very high. Its strength is a very large sample size, randomization to vaccine groups, inclusion of diverse site targeting different races and ethnicity, around 15 countries, and primary endpoint was occurring more than 14 days. And balance of participant characteristic were there. All the norms were maintained. And the Covaxin is also, the vaccine received DCGI approval for phase 1 and phase 2 clinical in July 2020. And by January, the vaccine is in public health. You can imagine what an enormous amount of work has been done within 6 months, from clinical trial to public health, from bench to clinics. It took only 6 months for the Indian scientists to make it happen. Sorry. So this is the salient features. For phase 2 were done in phase 1 and 2 were done sequentially, 380 subjects. High level of neutralizing antibody was seen. Higher neutralizing antibody twofold was observed in phase 2 rather than in phase 3. And both the vaccine groups elicited both Th1 based cytokines than Th2 based cytokines. This is one thing that it can prevent the breakthrough ones. Now the Sputnik is a heterogeneous recombinant adenovirus-based virus vaccine developed by the Gamalaya. Reddy's from India is taking charge of that. Showed a good safety profile and reduced strong humoral both immune response in participants. India began its phase 3 clinical trial with 1,500 participants across the India. It is a bridging study. In Kolkata, PLS Hospital is now being given charge of doing that. In Eastern India, this is the only site here. Interim analysis is 91.6% efficacy. It will conduct 25 hospitals. This is data from Russia, basically. Now, when and who? All the three vaccines that we talk about is 4 to 6 weeks apart in 4 to 6 weeks apart when it was planned initial recommendation from the CDSCO. Now the vector vaccines are recommended 6 to 8 weeks apart. The booster, longer the duration of the booster, longer is the better immune response because that anamnestic response in between the natural infection may act as the vaccination or inoculum. Till now, non-pregnant, non-lactating is the recommendation, though FIGO recommended recently that it can be given, and they cited a data in US where 40,000 pregnant women have been vaccinated without minimal side effects. These recommendations can go up to 12 weeks. So when for RT-PCR, if the prior RT-PCR positive, I think Rashau's one of the question was if their baseline was RT-PCR positive.
Yes.
Till now,
yes.
yeah, CDC guideline says that it from the day of test, it is after 12 weeks. That means 3 months. Roughly in India, we take the vaccine after 3 months. That means 90 days. Here is 84 days, 84 to 90 days apart. Those with symptoms and on convalescent sera or immune therapy. That was the CDC guideline. But there is a caveat. It did not say much about the mild or asymptomatic cases. In India, the government of the Ministry of Health is a little bit, wobbling on that. What we suggest is 2 weeks from the quarantine. That means if you finish your quarantine on day 17, you wait for another 14 days, you go, that means you're 31 days. After you become positive, if after first dose, if you become positive, you wait for 31 days and get your second shot. And if you have been positive and you have not received any vaccine, then wait for 1 month and then you can get the vaccine. For those positives in between doses, breakthrough. We define breakthrough a person who has SARS-CoV RNA or antigen detected in a respiratory specimen collected more than or equal to 14 days after completion the primary series of a US FDA authorized COVID-19 vaccine. This is the CDC definition of breakthrough cases. When we say a breakthrough cases, loosely it should be more than 14 days. If you get if you become positive, say after 2 days or 3 days, we do not call it as a breakthrough infection. It is a vaccine naive population. If you get RT-PCR positive after 14 days, we call it a breakthrough infection. 2 weeks from the last quarantine day, you can get the vaccination. That is 17 days plus 14 days. That is 31 days. This is all about the vaccine. I can take questions.
Thank you, Dr. Kanungo. That was a wonderful presentation, and you have really cleared a lot of cobwebs of our mind. And let us go straight to the questions. There are a lot of questions coming in. The first one is, how soon will vaccinations start to have an impact at the population level?
Yeah, it was in my first slide. This is an epidemiology, fantastic question. The we call, I mean, we go by, if you consider go by heart protection, uh, till now the eligibility is 18 years and above. So in a country of 137 billion, 100 billion, that is 100 crore population is eligible for vaccination, right? So for 100, if with a 60% coverage, so 60 crore people has to be vaccinated. 60 crore. For that, you need to have 120 crore doses. So if we, if you now just calculate the point for 120 crore doses, uh, I mean population, if you dose 30 lakh population a day, which we doing right now, we need more than 200 days, 200, I mean 6 months at least. So it is not political thing, but you know why? If there is a human crowd that not enough people are vaccinated, we have more than enough people. We do not have that number of vaccines, and no one in the world, no vaccine company, no, I mean, country in the world can vaccinate 100 crore population within a month. This is not possible. So if we go by epidemiology, 1 minus 1 by R0 or not, we require 69% population to be vaccinated, and for the to get herd protection of 100%. So 30% will be herd protected if you got 60% of vaccination. That means 120 crores of vaccines have to be deployed. So this will take around 3 to 4
Huge
months.
task.
Huge task. Huge. Not only that, if you consider the cold chain training, it is not an oral vaccine, it's an injectable vaccine. You have to have the long-term surveillance, you have to have the AEFI monitoring. It's a daunting task, but it's ongoing.
Hopefully before the third wave. We are ready.
Hopefully before the third wave.
There's another question saying, does vaccine limit symptomatic spread?
Absolutely. If you this is more or less basic science question. If I touch upon, three things can come up with the vaccination, which we have seen in India. We do the data is emerging. We are collecting the data. We are trying to analyze the data. Three things happen. First of all, as Dr. Mukherjee said, chance of mutation becomes less. More and people become, herd protected. Number three is severity, because the pneumocytes 1 and 2 gets protected with your vaccination. So severity is much less and the mortality is much less. If you look at the death among the healthcare workers in the second wave, it is much less because most of the healthcare workers have been vaccinated either by Covishield or by Covaxin.
How much protection can be expected after the first dose of COVID vaccine?
First dose of in any other vaccination, because both the vaccines, these are not live attenuated vaccines. One is the vector vaccine, another is the whole virion inactivated vaccine. After a single dose, with the asymptomatic exposure, natural inoculum, the first dose can there is some prediction that some first dose can act as a booster. It's a prime booster effect of that if you consider natural infection as the primary inoculum and second one is the first dose as the booster. With that view, people may think that it can confer enough protection, but there is no such supporting data that the one dose can protect. Okay. There is no such data right now.
Right. So at least
there's a question, Siddhartha.
Yeah.
After the second dose, do you need a booster dose after the second dose also?
Sir, there is a concept and trial is coming up, phase 2 with Covaxin, a whole virion inactivated vaccine. I'm telling you, this is we have already put up to DCGI 6 months after the second dose, the third dose. This is in clinical trial mode right now. This is not in public health right now. With the phase 2 cohort that we have with 380 population, we'll vaccinate the third dose. We'll give it the third dose and see the IgG level.
Have you got any concept about how long this second wave will stay? Epidemiologically.
There are few modeling have been done. We ourselves have done modeling with taking cue from the previous pandemics. it takes around 100 days to come to have a fall or steep. So we can, if we are very lucky, there. I mean, if the infection rate is like that, if there is no such natural calamity or break in a huge change in mutation, we can expect by July, if we are 90 days from April, May, June, it's May, June, July. By end of July, they'll be fall. This is a model. This is fitted into the model, and statistics do lie.
Right.
Dr. Kanungo, if you can please stop sharing your screen.
One question, Sugata,
There are a
please.
lot of questions for Dr. Kanungo actually coming.
Oh dear.
Yeah.
Okay. All right.
Dr. Nila Acharya has asked a question. Breakthrough data, when it was done, I guess it is pre-second wave phase. Enlighten us.
No, in between, because this data has been shared on 21st of April, so it is at the initiation of the second wave. I mean, I should say the middle of second wave, because just now it has started, so it is in the middle.
Dr. Pradeep Das has asked, after Covishield, few persons developed blister-like lesions all over. What is the explanation? Please enlighten.
Yeah, so there are these I mean, adverse events were noticed in UK even. These could be due to hyperimmune effect of the vector, the adenovirus vector, the CHAD vector. So that is so minuscule, and it was I mean, still the long-term follow-up is due, but the numbers are very less right now.
Right. Dr. Anshuman Goswami has asked, are there any guidelines for vaccination, time gap, post-COVID infection? One of my patients had just finished his quarantine after COVID. When can he go for this vaccination? I think you have touched upon it.
Did I? I think, yeah, I think I've talked about it.
You can please tell us in brief, because he has asked this question. I think.
Okay, see, if there was no vaccination, the subject becomes RT-PCR positive. CDC guidelines say that if a symptomatic or received immune therapy like tocilizumab or convalescent sera, wait for 12 weeks, right? For mild or symptomatic where there is a home quarantine, wait for 2 weeks following your quarantine. That means 17 days your quarantine days, wait for 2 weeks, that means 30 days.
Right. Dr. Shomen Mondol has asked, if I have had an allergic reaction like vomiting, fever with chill and rigor after Covishield first dose, when should I go for the second dose?
6 to 8 weeks, as usual.
As usual. Dr. Vishwarup has asked, since Covaxin is in scarcity, can the second dose be delayed till 6 weeks after the first dose?
Absolutely.
Right. He has another question. What will be the time for second dose of vaccine in a person who is suffering from COVID-19 at the scheduled time of second dose?
Did I answer that?
Yeah, I think you have already answered that. Pushpita ma'am has another question, I believe.
You finished all the questions. What I was trying to say is that here at the moment I'm in UK, and here they are going to give the booster dose in autumn, just like the influenza vaccine that is given every year. So they are going to give the booster dose in autumn. That's what they're planning. That's all.
Thank you. Another question. Patient has taken 2 doses of Covishield vaccine. Is posted for a planned surgery. Does he need a RT-PCR test for COVID prior to the surgery?
This is absolutely prerogative of the ministry. I mean of that particular region. I mean the state or the country. But what is practiced in West Bengal for 72 hours COVID negative is required. Vaccination, as you know, all the there is no vaccine apart from smallpox. No vaccine in the world can protect 100% protective against any disease. So, so current practice is that COVID negative within 72 hours of the surgery.
I think with the permission of the chair, I would like to answer this question.
Yeah, please. Please go ahead, Dr. Mukesh.
Hello, am I audible? Am I audible? Even if that person is fully immunized with Covishield or Covaxin, if you are planning to visit a healthcare facility for some elective surgery at the present, he or she should have a COVID negative report. Because like what Dr. Kanungo has already mentioned, vaccination protects the individual, but it does not prevent colonization of the virus in the respiratory tracts. So negative PCR report ensures that it is not spread in the healthcare facility. So negative report should still be needed, and it is best practice also.
Okay.
There is only one question, Siddhartha.
Yeah, please.
If you take one Covishield, can the next be the Covaxin?
There's no such data set right now. This is $1 million question we are already facing across India.
Same thing.
Yeah, I mean, the two trials are planned right now. One is the interchangeable, whether the interchangeability is there or not, whether it's safe or not. Firstly, safety, then it evokes enough immune response. The trial is upcoming, and in Russia there is an interchangeability trial is ongoing right now.
What is your concept? What is your idea?
I think it can be done, because with the I think it can be done in in rotavirus. I'm basically an enteric disease guy. I always fall back on enteric disease. So if we consider rotavirus, there are 2 rotavirus vaccines, right, and which are live vaccines. So these are found to be interchangeable, and this is used in Indian public health scenario right now. If there is one dose is mixed with one vaccine, other thing can be given, and it shows more immune response. So, but here it has not been tried right now. There is no trial, there is no data. Till now, there is no recommendation right now.
Okay, another.
Dr. Ghosh. Yeah. Dr. Ghosh, I think due to lack of time, I think we should proceed to the next speaker. And I'll request Dr. Sumon Kanungo to spare some more time for us so that we can, there are a lot of questions actually coming in on vaccination. So if Dr. Kanungo can stay back and we can carry on the discussion after the other talk.
Yes. Okay. One last thing.
I'll made it up for you, Dr. Kanungo.
Yeah.
Yeah. So
one last thing that had come up is how long does this immunity conferred by vaccines last? Is there any, like, we know there is no data, any estimation?
No, for natural infection, there are some data coming from China and UK. It is 365 days to 380 days in natural infection. But we hope that the natural infection evokes more, stronger immune response always. So especially with the viral disease. But we hope that it will be around 365 days. Studies on. This Covaxin trial, which I am the principal investigator, lot of answers will be there.
Right.
Dr. Kanungo, I am tempted to ask a quick question. Most of the doctors got the vaccination done earlier, so they had four weeks gap in between. So are they unlucky to have this short break in between the 2 doses, and they're more prone to vaccination vis-a-vis who are having vaccination after 6 or 8 weeks, second dose?
No, Dr. Paul, it's a good question. But if we again go, if we want to describe biology by statistics, 4 weeks versus 8 weeks, we have seen the GMTs. There was not, there are differences, but not statistically significant right now. But this is a good question, and it is too early to answer right now. Another cycle, maybe next year, we'll be able to answer this one. Good question.
Thank you. Please stay back. There are a lot of questions coming in. So I would request Dr. Rupak Kanti Vishwas, our next discussion, to introduce our next speaker, none other than Dr. Shyamashis Bandyopadhyay, and carry forward the discussion with him. Thank you, Rupak.
Yeah,
please go to slideshow to talk.
Yeah, this is Anshat. Yeah.
Yeah, it's visible, Rupak.
Slides visible?
Yeah.
Okay. So this is my pleasure to introduce Dr. Shyamashis Bandyopadhyay, and he's one of the known face since the COVID infection from last March to 2020, and he's a known face in all the TV channels. Shamash he did his MD from Medical College Calcutta, and after that he has gone to UK to complete his MRCP and CCST. And after his training program is over, he was a senior clinical lecturer in Bristol University, and then he became consultant physician in Bristol Royal Infirmary, and he was Royal College tutor and postgraduate tutor as well there. So he has a lot of activities there in UK. And after coming back from UK, he became director of medical services and senior consultant physician in the Department of Medicine and Rheumatology at Apollo Gleneagles Hospital, Kolkata. And he has multiple, obviously he has a multiple national and international publications, and he has a wide experience on research in this fraternity. Currently, he is Royal College MRCP examiner and DNP tutor examiner as well. Shamash, I think you want to speak on your example, please.
Yes, thank you very much for giving me this opportunity once again to come in front of all the esteemed ophthalmologists. I've got a very bad eye. My power is minus 14.5. So I've got enormous respect for ophthalmologists. Now, I'm not a scientist. I'm a practicing doctor, and I'm seeing patients. So I've got few observations which are not necessarily backed up by data collection. And just listening to Dr. Kanungo's fantastic presentation, I was just cursing myself that if I could have collected the data for last 14 months, I had an enormous live data set with me. But leaving aside that, what I have seen with a turnover of about 100 patients a day of COVID, both severe and mild. If I have seen that in our West Bengal medium to high social economic status population, the native infection does give you about 3 months of antibody to the max. The IgG and IgM I'm not talking of NK cells or Th1 or Th2 because you don't measure that in normal practice. The IgG fades away within about 3 months or so. I have a lot of my patients have tested after their native infection, and that's what we have gathered. And that is a real-time data. The second point is that if the infection is mild, the antibody is even milder. If the infection is mild, the antibody production is even milder, and the chance of reinfection in the second wave for those people I'm seeing is higher, which is in line with the coronavirus infection trend as per the virology book. So milder the infection or asymptomatic the infection on the first wave, higher is the chance of second infection because the antibody response is also limited. The native infection, one difference I have seen from the native infection and the vaccine induced antibody formation is that in native infection, the total SARS-CoV IgG antibody is higher, but the spike protein antibody is not that high. And in spite of a total IgG against SARS-CoV-2 remaining positive or present, the spike protein antibody tends to fiddle away. And we have done a spike protein antibody, and we have published in JAPI on our healthcare professionals. The persistence of and spike protein antibody in a healthcare population group of about 4,500 people. Whereas in vaccinated people, I have seen that the total SARS-CoV antibody response is not that high, but the anti-spike protein antibody remains high. So that's an observation. I'm unable to provide you the data, but we are in the process of looking into some of the data which we have. But obviously, being a clinician, my ability is very limited. The second important issue I wanted to touch upon is that a lot of people are telling that we had the first dose of vaccine and then we had the infection. And very casually relating the vaccine with the infection. My take home is that one who had the first dose of vaccine and continued to have COVID behavior, proper COVID behavior, did not get the infection. Nowhere in the planet it was told for any coronavirus whatsoever, leave aside COVID-19, that vaccination will prevent acquisition of infection. So as Anjan and Dr. Kanungo said, that colonization of the respiratory tract after the vaccination is possible and well documented. Similar thing happens with anybody who fails to adhere to proper corona behavior. The third point, I think we all need to understand that corona is going to stay. This is going to be the second wave, and there will be third, fourth, fifth, sixth, n number of waves. Because there is no reason why it shouldn't be. The only bit about it is that we are in an active vaccination mode, and as in UK, Shumitra said that they are going to vaccinate in the autumn again. I'm sure once we have vaccinated our population, we will have similar trend of vaccination for a affluent population, because I cannot believe that our government will be able to vaccinate free of cost to the population over 45 for years and years and years. So there will be an element of affluency which will allow you to buy your annual COVID vaccination. For day-to-day life practice as a clinician, I'm sure you will be not doing your surgeries which are not emergency for the time being. Now, there is an element where cataract surgery will become emergency on a very mature or hypermature cataract, or retinal detachment, or some sort of trauma, or there will be hemorrhage. So you will have to have these emergency surgeries. As clinician, you will face the same risk of acquiring the infection, regardless of the fact that you would be doing within 72 hours corona negative. The test, in best of the hand, like Anjan, will still have 30% false negative. So, and you cannot afford to do 2 tests to make it about 90% before you go for an emergency surgery. That's not possible. And more we are depending on this quicker test modules like CBNAT, TrueNAT, these sort of things. And one observation there is that the nasopharyngeal swab has a better yield than the oropharyngeal swab. The oropharyngeal swab has got about 50% yield, as I understand from the CBNAT platform. So an open RNA RT-PCR remains the mainstay of investigation for coronavirus. So if Anjan is thinking of any respite in near future, he is mistaken. From vaccination point of view, after an infection, my thumb rule is a month. From the date of recovery or from the improvement, my thumb rule is a month, and that falls in with Dr. Khan's scientific deliberation that generally after a month you can have the vaccination. There is a lot of hoo-ha about the CT values, and a lot of people, especially the erudite section of our society, they are very, very attached to the CT value of the COVID test. And they still hold deep in their heart the feeling that if CT value more than 24, you will not have any problem. Unfortunately, life is not that simple with the CT value, and CT value has got some correlation with infection, and WHO did once propose way back in September, October about the CT value, but in real life, the CT value will not guide much about the treatment options which are needed. There is question of remdesivir, and there is lot of WhatsApp university guidance, which at times modify our governmental guidances as well. Is that remdesivir is useless? That's unfortunately or fortunately not the case. For hospitalized patient for mild to moderate severity who is needing oxygen, remdesivir and steroid does work. We have given a lot of remdesivir, lot of steroid, and it does work. The only thing is that initially there was a talk about remdesivir with dexamethasone, but Gilead Sciences have taken away and has given clear guideline that dexamethasone and remdesivir does not cross-react. And from the steroid perspective, our age-old dexamethasone, which is 4 rupees, is more effective possibly, although there is no head-to-head trial, but is actually equally effective, less not better, than any other steroid form. So you don't need to spend 500 rupees for steroid. Your 4 rupees steroid is fairly good, and a short course of dexamethasone for people who are needing oxygen is very, very, very cost-effective treatment, and at times life-saving treatment. On the contrary, please do not use steroid if you don't need oxygen. Trials have shown that steroid given to people who doesn't need oxygen actually cause more harm than good. So steroid is not something for everybody, but steroid is effective for moderate onwards disease, and steroid has got mortality benefit in ventilated patients. And I will stop after the last point is oral favipiravir. There are weak evidence that favipiravir started very early on the illness can actually decrease viral shedding and reinfection. So being, what Dr. Kanungo was saying, that the R naught of this corona is pretty low. So people are getting infected in the entire family. From clinician perspective, the differences of first wave and second wave is 3. 1, more younger people are getting infected than last time. It is not only the comorbidity which is causing them to come to us. Second point is that people are very small percentage of people are getting serious complication of the disease early on. What I mean, that last time we had this blanket idea that we will start thinking of complication from day 5, day 6 onwards. Day 2, day 3, don't bother. they are fine. And that was the norm. But this time, we have seen a very small portion of people who have gone downhill in day 2, 3 downwards. So this time, maybe that is one point we need to look into a bit more detail, but that's what our clinical observation currently are. And the other issue is that people are, again, WhatsApp University are spreading this rumor that this coronavirus, you cannot pick it up through RT-PCR test. This is a novel virus, so this needs a novel investigation. That is not true. This virus, regardless of whatever genetic, 1 mutation, double mutation, triple mutation, this virus is still jolly well picked up by the standard RT-PCR kit because they target the gene which is not in the mutation category. And I would end by requesting all of you to stick to the basic corona norm. The basic corona norm will stay the same for next 50 years. Because those of us who are in this webinar, we will not be there after 50 years. So for 50 years, the basic corona norm will be mask, hand wash, personal hygiene, and social distancing. The mask, I would once again tell, do not touch the outer surface of the mask and then touch any part of the body. Because what you are trying to prevent is all there in the outer surface of the mask. The same coin, do not touch the inner surface of the mask, because if your hand is not properly sanitized, you will infect yourself. So please keep these masks, in your mind. Small things, but does make a lot of difference. And you do not get infected because you had a poor donning, or you had a poor ventilation, you had a poor PPE. You get infected because your doffing is bad. You are not doffing properly. So those of you who are seeing corona patients, who are getting into PPE, please concentrate on doffing. You must give little time to doff rather than doff in a hurry, and that's where you will get infected. I am equally vulnerable as you all are. I also make mistake a day, but I tend to tell myself during the time of doffing that I must not hurry for doffing. So that's very important, because why I'm saying so, we are going into emergency where we're not on a PPE, we're going with an N95 mask, and there are open people who have suddenly turned out to be corona positive. So unless you are there for long, you are okay with your N95. Do not touch the front. Thank you very much.
Thank you, Shyamashida. I think this is very elaborate, and again reminding the basic of the grammar, that not to touch the front part of the mask, and those little small tips. I'm sure there is a lot of questions are there in the queue, but we will take few of them very shortly because of the time. So Dr. Sudipto Das has asked you, what is the percentage of asymptomatic patient in the second wave, and can these people still be the super spreader?
Asymptomatic patients, if they don't know their corona status, or even if they know their corona status, they are the most vulnerable population for us. They are fine for them, but they are most vulnerable for us. It is simple human nature. I know people, myself, who has become corona positive and traveled in a taxi Uber, gone to Howrah station, boarded a train, and gone to his own native land in Bihar. Just imagine the number of people he himself has infected.
Given it. There is a quick question. As you told, young and even the pediatric age group also being affected compared to the more number of people are getting affected, and these people are not exposed to the vaccine. So, do you think that the infection kind of infection you are handling is different compared to the vaccinated population?
No, thankfully, I'm not a pediatrician. But what information I gather from the pediatric colleagues, because we work very closely side by side, is that unless the childs are getting Kawasaki-like syndrome, because corona is one virus that is giving Kawasaki-like illness. So unless that is happening, children are doing very well. There is no problem in normal children population being treated. It is only the Kawasaki-like picture which is creating problem for the coronavirus, I mean for the child. And so far, diagnosed early, treated with IVIG, this Kawasaki-like syndrome is very, you can treat them well, provided you can afford that diagnosis, you can afford that IVIG.
There is a common belief, there is one question, is a common belief that this trend, the new second wave, is much more infectious, but this is less severe in terms of mortality. So do you think so?
No, absolutely not.
So this is equally severe, along with higher infection rate.
For the population who is getting the infected because of the more younger people, because of more asymptomatic people, because of sheer more number, you are getting more infection. But if you look at the death rate, if you look at the ventilation rate, if you look at these sort of parameters, it is not still, there is no document to show that this is more severe than the last time. Anecdotally, yes. Anecdotally, 1 or 2 young people have died. Now, anecdotally, 1 or 2 young people died last time also. The message in the WhatsApp university is coming because you have got 3.5 lakhs infection a day, where you used to have maximally 97,000 infection a day. So you have tripled or 3.5 times increased your infection. So your anecdotes will also increase. That's understandable.
Overall number, yes. So HCQ and ivermectin role.
Once again, I feel very sorry for HCQS or hydroxychloroquine. I have, as a rheumatologist, that's one of my most favorite drug. I think it did not get enough chance in the last time because obviously it did not make any money out of it. Ivermectin was never a very big target. The fantasy of ivermectin has gone. There is one documented area where you should use ivermectin, no question, is when you are using steroid. It is not bad to give one ivermectin dose because you can then stop the strong alloy migration in the lungs. So that is where it all stays regardless of anything else. But as an anti-corona, I think ivermectin got a bit of a hype than anything else.
Can I supplement to this?
Yes, please. Of course.
Actually, this is a very good point that has been raised. If you look at the head-to-head data with in vivo data with HCQ and ivermectin does not stand to HCQ. HCQ is much more superior. There are lots and lots of data on HCQ. Even
HCQs did not get what it should have got.
Yeah, even আমাদের যে 23rd আমরা যে we have circulated the treatment guideline. We did not adhere to ivermectin. We still adhere to HCQ. If you look at our 23rd April published data, I mean treatment guideline, there ICMR, we did not.
No, that is 23rd of March.
April.
Oh, I haven't seen that yet.
I can share with Shugato. Can.
Okay. But will taking HCQ after vaccination, will it not subdue the vaccination role?
No, it's taking HCQ as a treatment. Shamasiza was talking about HCQ as a treatment.
No, okay, but some of us used to take prophylactic HCQs.
Yeah.
After the vaccination, I heard in one of the webinar that you shouldn't be taking HCQs after vaccination because it might make the vaccine work less. Is that correct, or is it again from WhatsApp University?
WhatsApp University.
WhatsApp University completely.
Absolutely.
If I know you don't have any time, but I cannot resist myself. I'm sorry. This HCQS and vaccination came from rabies vaccine saga.
Right.
In South Africa.
Right.
So what happened? They gave rabies vaccine, and the population did not get immunity. So they looked into it, and they saw that they were taking chloroquine for malaria prophylaxis.
Malaria, right.
Or malaria prophylaxis. And WhatsApp University picked it up and made into webinars also in scientific forum. That's
Absolutely.
the power of WhatsApp University. It's amazing. HCQS you can jolly well take. I still take HCQS prophylaxis myself. Sunday is my day. I know ICMR has done trial. I have participated to that trial. That trial has not come out to be positive. Having said that, trial has not shown that HCQS is doing any harm either.
শাবাশিস দা আমি পিআই ওটা বেরোচ্ছে ওটা মিসক্লাসিফিকেশন করে পেপারটা বেরোচ্ছে ওটা পাবলিশ হচ্ছে ওটা হচ্ছে পাবলিশ
But at least I know that it has not shown any
it did not show
any non-inferiority.
Right, even non-inferiority it failed as a among healthcare workers as a protective, as a prophylaxis, but we publish it in a different light. It will come next month.
But essentially for treatment purpose, so far whatever data is available, hydroxychloroquine, as I said, I myself have got a lot of faith in it, and I think it did not get enough respect it deserved, because it is not available in United States, it is not available in many countries in European Union. Hence, we did not have the muscle power to establish it as a treatment. That's the fallacy on our part.
Absolutely.
There is a question, Shamashish. Hello, Shamashish. I had HCQS for 6 months. I was told to stop it after my first shot. Should I start again, or should I
No,
still?
the prophylaxis is something different. Prophylaxis data did not come out. The prophylaxis was not. I don't know. Shuman will know it more than me, but prophylaxis, no.
Prophylaxis in the healthcare workers, it did not show any benefit. This is unofficial. I'm telling you, I will publish the paper next week. It was done 10 sites across India, and Kolkata was not one of the sites, but the other sites, prophylactic. But Shamashishda was talking about treatment as a treatment. Prophylaxis, I mean, it did not show enough. The data was powered, but it did not show enough protective. This thing.
I have a question. In daily life we face this. A patient has recovered from COVID-19 disease 2 months back, and now does he need a RT-PCR test for COVID-19 before a planned surgery?
Yes.
Absolutely.
Having antibody does not give you a protection for not acquiring COVID if your COVID hygiene is not good.
Some patients who had seen it still comes positive, RT-PCR still comes positive. When we talk to the lab, they say that maybe he doesn't have active infection, but those virus, particles.
If you're going for a surgery, see, there's a difference. Let me clarify that for all the surgeons, because you guys are all surgeons. See, for the patient, once you are an EELE symptom, i.e. you are a mildly symptomatic person with EELE symptom, 10 days you are non-infectious. If you are a SARI symptom, 20 days you are non-infectious. End of story. But this RT-PCR is not done for the patient. This RT-PCR is done for you guys, because we still don't know whether that patient will be able to infect your hospital or your clinic or your nursing home. That bit of knowledge we still don't have, because the infectivity of CDC driven guideline, which is 10 days for EELE, 20 days for SARI, is for spreading to other people on casual contact. But here you will have close contact. You need to intubate the patient. You need to give nebulizer to the patient. You need to create aerosol for the patient. So you don't know that scientifically. Shuman, am I right?
Absolutely. Absolutely.
So
Actually,
it is for the prevention of all your other patients. For that patient, he's fine. He can have whatever he wants to do.
even 46 days, 47 days, the viral VLP, virus-like particles, the engulfed endocytes, engulfed things, they may amplify and come as positive in RT-PCR. But as Shamashis rightly said, this is for yourself. You are working in a closed environment. So please stick to the dictum of 72 hours. Within 72 hours, he has to be negative for any elective surgery.
Right. I think we have to go to the next speaker. Otherwise, we'll be punished.
No. If you can stay back, we can have some time for discussion. Thank you so much. So, can I invite Dr. Oyan Mohanto to introduce the next speaker, Dr. Shivabroto Banerjee, please?
Can you see my screen?
Yes.
Yeah. I'm honored to introduce Dr. Shivabroto Banerjee, who is a senior consultant internist, Fortis and Apollo Hospital. Dr. Shivabroto Banerjee has done his MBBS from RG Kar Medical College in 1992, MD in internal medicine from NRS Medical College in 1997. He is a chief consultant physician, Fortis Hospital, Anandapur, also a senior consultant physician in Apollo Hospitals, Kolkata. He is working in the field of internal medicine for the last 24 years. He was the honorary joint secretary of IMA headquarters, Delhi. He is now acting as joint secretary, Indian Medical Association, Bengal. He was an EC member of Association of Physicians of India and a member of Indian Society of Critical Care Medicine. He was awarded with Professor of Medicine in 2020 by IMA. He is also an important member of protocol monitoring team for COVID-19 on behalf of West Bengal government. He is leading from front his COVID team in Fortis Hospital. Over to you, Dr. Shivabroto Banerjee.
Good evening. Thank you very much for inviting to participate with this honest learned gatherings. It's very difficult to tell something after Shamash there. So my topic today is post-COVID recovery. So before entering into the post-COVID recovery, let us recapitulate. We have started our journey with the discovery of this virus in 10th January in Wuhan city. After that, a long path we have traversed in last 1.5 years. And now we are facing the second wave. Now, let us introduce the disease in a different manner before entering the post-COVID recovery. In different literatures, this disease is defined as acute, manageable, immunogenic, thrombogenic, inflammatory, contagious, novel virus disease pandemic. So this sentence is very much self-explanatory for its acute management as well as post-recovery management. Just let us spend 1 minute on this sentence. Acute, we know this disease is acute, but there is a fallacy. After completion of the first wave, when we were not sure we'll get the tsunami of this second wave, almost all important hospitals were opening their post-COVID clinic. So there is a chronic aspect of this COVID. 100% it is manageable disease. It is immunogenic. There is no confusion in it. Thrombogenic, already we know lot of persons we have lost due to its thrombogenicity, and there is a role of heparin and low molecular weight heparin. Of course, inflammatory process, as it is an infective disease, contagious, there is no doubt, and it's a novel viral disease creating the pandemicity. So, before going into the post-COVID treatment part, let us look at the virus for 1 minute. Initially, predominant was B.1.17, which is UK variant. Next is the B.1.351, which is South African variant. Third is the P1, which is Brazilian variant. Now let us look at this variant. The first one, which was most predominant UK variant, almost we are clinically dealing with that, we are fighting with that. Next, the introduction is the South African variant with some mutation, where we have seen the transmission slightly escalated. But in the Brazilian variant, we have seen 3 aspects. Number 1, in our body, antibody created by the vaccine or previous infection very often escapes the virus. So number 2, there is a chance of reinfection. Number 3, sometimes it is found it escapes initially RT-PCR diagnosis. So in that case, repeat test is mandatory. And the most important part, no age is spared in Brazilian variety. But interestingly, in Maharashtra, right at this moment, is getting predominant. That is the double mutant virus. That is variant, that is B.1.617. Though the double mutation term is slightly fallacious, but 2 most important.
Can't hear you.
So you are not audible.
Can't hear you, Dr. Subhabrata.
Banerjee, you are not audible.
Dr. Banerjee, we can't hear you. Hello? Dr. Banerjee? Sugato?
There must be some problem in, he is still online, must be some problem.
I'll call him. In the meantime, you can start taking some questions with the other speakers. If you want to, I'll calling him.
Okay.
Or we can, I'm just calling him, or we can invite Dr. Rupak Borua, Mr. Rupak Borua to start his speech. That just hold on for a second.
That will confound
Please
the...
call him and reconnect.
Yeah.
One question for Shamashishda.
What is the name of that?
He is not taking up the call actually, and he is not realizing that we are not hearing him.
So can the tech team help?
I think we'll move on to next speaker. In the meantime, we'll reintroduce him.
Sugato, anyone from the tech team?
Yes, yes. If the tech team can unmute, I think he has got muted. If someone can unmute him.
Sir, we are sending him an unmute request, but I guess he's not looking at that, sir. We can't
He's not
unmute.
taking the call either.
Yes, sir. We are continuously sending him an unmute request, sir.
Okay.
Unmute. Dr. Banerjee, please unmute.
So
you are not audible, sir. You are not audible, sir.
So you can call him up now.
okay, I'll request Dr. Devashish Das to introduce Mr. Rupak Borua and let him go ahead with his talk. I'm trying to call Dr. Shivashish Banerjee in the meantime.
Are you listening?
I was trying to call you actually. Your thing got muted, so we missed a bit of your talk actually. I was trying
From
to
the
call you.
Brazilian variant, I think we could not listen to. Yeah.
Sorry?
So
when you are talking about,
I think if you log out.
Are you listening?
Yeah, now we can hear you.
We missed a bit of your talk.
You can't listen.
There was no audio.
So I think if you log out of the meeting and join back.
No, now
Just
it is
a
okay.
moment.
Now it's okay. Now it's okay.
So he doesn't need to go out. You can hear him now.
Can you?
Now we can hear you.
Okay. Can you tell me how far you have listened or you have not listened at all?
From the Maharashtra infection, these Brazilian.
Okay. Now the part. First one is UK. Second one is South African. Third one is Brazilian, which we got in India. But right at this moment, in Maharashtra, which is getting predominant, is the B.1.617. Now, in this variant, what we are getting very high transmission rate, and we are getting combination of the two mutation. One mutation is a Californian mutation, which is showing very high transmission. Another is South African and Brazilian mutation. These two mutations are getting combined in this newer variant. Now, why I am telling these variants, reason behind, we do not know after 2 years or after 10 years, when we will discuss post-recovery COVID challenge, at that point of time, it may be from which variant the patient was contracting the disease, that may depend his post-COVID clinical symptoms. Now, let us enter into the post-COVID symptoms, which are most important. We are usually asking few questions. One is fever, chest pain, dyspnea, fatigability, polyarthralgia, and brain fogging. Now let us enter into the most important part, is the fever. Very often, we are getting patients having fever post-COVID up to 2 months. I am having few patients. Now the question is, even after doing thorough investigation, we didn't get any clue. So in that case, the most important question, whether we will give some steroid to these patients or not. I have gone through literatures. There are some contradictory suggestions, but in a nutshell, after exclusion of any superadded infection, we may have a short course of trial steroid in these patients for recovery from the fever. If we go system by system, sometimes in central nervous system, we are getting patients who are having post-COVID stroke or seizure. Very often, we are getting patients who are not getting yet taste or smell, which are peripheral nervous system manifestation involving the cranial nerve 1 and sensory part of the trigeminal nerve. Very often, as a part of the cardiological aspect, we got patients who are having acute coronary syndrome post-COVID and evidences of myocarditis. Most important part, as far as respiratory part concerned, very often we are getting patients who are having good HRCT, very good HRCT, good HRCT recovery. But in those patients, if we do 6 minutes walk test,
we have seen significant dropping of the saturation and increase of the pulse rate. Even in other group of patients who are having bad HRCT, in those patients, we have to monitor properly the HRCT, whether the pulmonary fibrosis is progressing or not, and in that case, we have to do repeated 6 minutes walk test to assess the function of lung. Sometimes patients are also complaining of irritable bowel syndrome like features along with some sorts of transaminitis. Very interestingly, we have seen few patients who have developed thyroiditis, uncontrolled blood sugar in almost all patients, particularly those who are getting steroid. That may be a part of drug-induced impaired glucose tolerance or some involvement of the beta cell. And very often, there is a very good observation, the patient who were pre-COVID part normal epidemic, post-COVID, they developed dyslipidemia, mostly hypertriglyceridemia. That is usually we are getting. So these are the most important post-COVID challenge, yet we do not have any structured management process. We are trying to sort out one by one, but unfortunately, for the time being, again, we are busy with the management of acute COVID. So again, these post-COVID recovery patients are in back foot, and some of the patients again develop acute COVID. So I have tried my level best to cover the post-COVID aspect, and now I am requesting our moderator, if anyone have any question, I am ready to answer. Thank you very much.
Sugato, do we proceed with the question answer session? Or?
Yeah, we can have a couple of questions, and sorry to keep Mr. Barua waiting. He's a very busy person, but thanks to his patience. So just go ahead with a couple of questions, and then we can invite Mr. Barua. We are all waiting for his assurance to the doctors, actually.
Yeah. Hello, Sugato.
Yes.
Questions?
Yes, a couple of questions, and then we can move ahead to Mr. Barua's speech.
Okay. So one question is, when do we start a regular work post-COVID? I mean, since one of us might get affected, and when can we resume a normal work, normal OPD activities and operations, things like that?
Very interesting data are there. I have seen data globally. In 2 months, proper resuming of normal activity in only 13% of patients. Proper. 67% of patients, after recovering within 1 month, they have joined in the job, but not in a proper manner. So our suggestion, after recovering from home isolation, if you feel clinically fit, then you can jolly well join your job, but better to have your post-COVID investigation profile.
One question from Dr. Rakesh Kumar Gupta. During home isolation, if all the members of the family have their own room, can they keep their masks off?
If one COVID positive patient is isolated in a single room and no one is entering in that room, in that case, he can take off his mask. There will be no problem.
Another question by Dr. Utsav Pan. In mild symptomatic COVID positive, even after vaccination, should doxycycline and ivermectin course be done?
There is no relationship with vaccination and treatment. these are two different parts. So even after vaccination, if a person is suffering from acute COVID, we have to give management in the line of acute COVID. That may be doxycycline, ivermectin, or whatever.
And how long should the acetylcysteine should be continued post-COVID? I mean,
Acetylcysteine is purely symptomatic treatment. So whenever we'll see patient is not coughing out any mucus, it's a basically mucolytic agent. So in that case, we can off the medicine, and sometimes we are using acetylcysteine for improving the creatinine level if the patient is having ARF. So in that case, we have to keep an eye on creatinine, provided the potassium is normal.
And what about exercise and physiotherapy?
6 minutes walk test before starting exercise and physiotherapy, I think, is a mandatory. One day at least you should go through a 6 minutes walk test, but incentive spirometry for all patients must be done.
Thank you. Any other questions from the house?
I have a
Any
basic
questions
question.
from the panelists?
Yeah, well, I have a basic question. What are the post-COVID investigation protocol? What does it include?
Yeah, post-COVID investigation protocol, number 1, HSCT thorax, ECG, echocardiography, from blood, CBC, blood sugar, urea, creatinine, sodium, potassium, LFT, lipid profile, thyroid, and 6 minutes walk test. And sometimes we are doing urine RE ACR also if the patient is having any acute renal injury.
Sugata.
Thank you. Yes.
Sugata,
Yes,
can
yes,
I say something?
Yes, please.
I actually have a couple of observations, not questions as such. First of all, I would like to congratulate and salute our physician friends. You know, they have done such a signal service last year and this year as well. I think they'll be remembered for decades, actually, for their great service to our society. That's one. The second thing I find is that, you know, they have got a tremendous knowledge bank from their expertise and experience. I somehow find that that knowledge has not trickled down to the level of the local para GPs, because I still find that there is a lot of confusion and a lot of differences in the approaches to COVID patients. And being a COVID survivor, I know the only thing I would like to have is a physician who knows what he is doing. I'd like to get treated in my own house without complication. And then if I need, then I need to be transferred to a hospital. But, you know, the kind of knowledge that I see here, unfortunately, it's not always evident in our, you know, grassroots level. I don't know how to tackle that situation, but it's a valid situation. I talk from experience again. A neighbor I have who has been admitted in a fairly serious situation at Arentego this morning. And I think there was a bit of a problem with the way things have been done, without blaming anybody. So that's something which our physician friends can think about, to how to trickle down that knowledge to the grassroots.
Actually, I'm commenting. Actually, as this COVID chapter is absolutely new chapter, and from the very beginning, we have a lot of turns and bends. Suppose I'm telling you one example. When we have started treatment, we had a concept no steroid for the COVID. Now we are in a situation always steroid for COVID. When we started, we had a concept earliest ventilation. Now the concept is last ventilation. So we have a lot of turns. So it's very difficult for all physicians or practitioners to keep in pace with this changing scenario. So we have to do this type of webinar continuously to be in touch with them so that we can enrich ourselves with this changing process.
Thank you very much, Shivabrata, and thank you for sparing your valuable time. You are so busy. So thank you very much for your time. I think Dr. Saurabh Sena wants to ask a question. Saurabh, no, okay. So may I request Dr. Devashish Das to welcome Mr. Rupak Barua, and I would like to thank Mr. Barua to patiently waiting. Sorry to keep you waiting, sir, in your busy schedule.
No issues. Yeah.
Devashish Das, please. Dr. Devashish Das, please, your slide is visible. If you can introduce Mr. Barua, please go to slideshow in the bottom of the screen. It was in the slideshow mode earlier actually, but you can introduce him.
Yeah.
Dr. Devashish Das, please.
Yeah. It gives us a great pleasure and honor to introduce Mr. Rupak Borua, who is a group CEO at the Amri Hospitals. He joined Amri in the year 2014 after the great tragedy it happened in 2011 at the Dhakuria Amri. And he has steered Amri Hospitals again to newer heights with his own marketing leadership. Previous to Amri, he was at CMRI Hospitals and BM Birla Heart Research Institute, both of which belongs to the CK Birla Group. He had completed the management and the management development program at IIM Ahmedabad, as well as at IIM Bangalore, as well as Singapore Management University. At present, he is the Vice President of the Association of Hospitals of Eastern India. He is also the Chairman of the CII Healthcare Subcommittee in the Eastern region, as well as he is an active member of the Bengal Chamber of Commerce and Industries, BCCI, and is also the National Expert of Healthcare Committee of the Indian Chamber of Commerce. With this, I request Mr. Rupak Borua to present us with his dialogue on the logistics of this present pandemic scenario. Mr. Rupak Borua, please.
Thank you so much. Thank you so much. Thank you, your Ophthalmological Association of Bengal, for inviting me. This is a very important discussion that I was just also hearing about. A lot of advancement is taking place from Dr. Shyamashis, Dr. Shivabruta and all. I'm not a doctor, so I will not go into this any clinical area, but I would like to stick on to the infrastructural and where we are right now and what are the issues, challenges that we are facing to treat the patient and way forward. Now, the major issue, if you see that what is happening and that the last pandemic that started, though it started maybe December, January or whatever, but we started facing it from the March. And then it's picked up in the month of around August, September. It took almost 4 to 5 months time to reach to its a peak level. But the difference between the last year and this year, that it in 1 month, it has picked up. So early March or second to third week of March, actually, we started feeling that, yes, of course, maybe the second surge. We were discussing about in many forums and all that there is a second surge is supposed to come and all those in second surge, third surge, because that everyone has observed earlier as well. But so we are all expecting that there is something is going to happen. Now, the sudden it is going to happen in this manner, it was not expected. So there is a huge shortage of beds right now. Now, there are a couple of issues, challenges, advantages, disadvantages that what we were before last year, and this year. See, the last year challenges was different compared to this year. Now, last year, actually, major part is that that's a very new virus. We were not having much of idea about this behavior. So we are very skeptical, actually, handling patient. Now, there are major challenge we had faced, that is getting this year COVID protocol safety gears. That is the major part. That's N95, which you're talking about, PPE and all. And the protocol also were not set. So it was a huge challenge. during this year, end of March, actually, we got the what you call it, lockdown, and there is a huge disruption of the supply of the material. So that was all those things happened. Now, somehow we could manage, and we could develop the system protocols and all, and we could manage the situation very well managed efficiently. Now, this situation actually what happened, that is, though we were, yes, of course, we were prepared with this your safety gears and all. There is not much of shortage that we are still facing. There is other areas where doctors are quite conversant with the treatment part, and also they were also knowing. So immediately we could start the treatment process and all, and we could started handling the patient. The major difference happened between the last year and this year. That is the number. The major difference is that this year we were still maintaining with the non-COVID patient, because the planned surgery was going on. There is almost all the private hospitals. There are quite good number of non-COVID patients, general patients, and the patients those were, that waiting for surgery for last couple of months. So they started coming up in the system. So there was a good number of surgeries started happening. Now, sudden increase of this your COVID patients and converting those non-COVID beds to COVID beds, it was a very challenging part. So somehow, see, during this last pandemic, that is last year, our private hospitals cumulatively, we were having around 6,000, 6,500 beds. I mean, I'm talking about the Calcutta. Now it has gone down to level of your maybe 1,000, 1,500 during this year, January, February kind of a situation. Now in the month of March, or third week of March, fourth week of March, or early April, from 1,000, 1,500 beds, we could manage to increase to 3,000, 3,500. And as of now, today, almost all the private hospitals, they have increased the number of beds to 5,000, 5,500, though government is asking to reach out to more than the last year, that is 7,000, 8,000 beds they are asking for from the private sector. So increasing the bed actually is not the issue. Issue is that the critical care beds. Critical care beds is an insufficient number, as you all know, because you are all doctors, you know how difficult to manage a critical care patient. So, and the infrastructure as well, the monitors, your ventilators, those is not in a ready available. Suddenly increasing the number is also a big challenge. So that's the issue that we are facing, that insufficient number of beds, day in, day out. Right now, we are refusing patients because patients are also desperate to take their next of kin to the hospital. Many patients, we are saying, no, there is no bed. If I just give you an example of my hospital, AMRI hospital, we are having 3 hospitals here in Kolkata. Now, during the peak time last year, we could increase the bed status to almost 300, 285, 300. Now, this year, then in the month of January, February, we could slow down to this year 50 number of beds in the group level. From 50 of the number of 50 beds in the month of March, early March, we have increased now to 450 as of today. Out of the 7 buildings, 7 towers which we have in 3 locations, out of the 7 towers, we have converted 4 towers as a COVID hospital. 4 towers, dedicated COVID hospital. Even in the Mukundapur, one of the tower, that is a very state-of-the-art boutique part, that 120 bed we have just started 2 days back. And you won't believe, initially we started with the 70 beds. That is in one day, it's full. And now today I had to force, because there were shortage of manpower, as you all know. So then today only we had to start another 20 beds because the 20 patients were waiting in the emergency. So we had to accommodate. So somehow we called the nurses and the doctors out of their roster, and we had to put them into duty. And we started additional 20 patients, and in 20 minutes, 20 beds full. So that is the question, is that it's an increasing, as we all time our government's notifications, our commission, because we have a West Bengal Health Regulatory Commission. So we are having regular discussions with them and the bed augmentation part. But the question is, how many beds we can increase? The positive cases which is happening today started with 5,000, 4,000, 5,000. Now it has reached to 14,000, 15,000. If there is a 10% patients wants to get admit, there is a no question, no healthcare infrastructure can provide those beds. So the problem is this: the bed is a huge crisis. Now, one thing we could see that is that the patients, those who doesn't need the admission, somehow they are rushing to the hospital because of out of fear. Now that we need to, that's why we have created actually that satellite center. You must have seen that satellite center we have created, that is the extended hospital, that is in the hotel we have started, and that's, we call it extended hospital. But still patients are not willing to reach out to that, or the patient's family, they find that maybe the hospital is much safer, so they don't want to go to the hotel. Still, yes, of course, the patient now started going to the hotel, but these are a very, very severe crisis situation that what we are facing. And I don't know what is going to happen tomorrow. If this thing continues, it's very difficult for the healthcare infrastructure, whether it's a private or the public, both way, but it will be very, very difficult to handle this situation coming days, and not very too far. I'm talking about tomorrow, day after tomorrow itself.
Thank you, Mr. Barua.
I understand the situation is very grim as of today. Can we put forward a few questions, Sugato? Sugato, can we go ahead with a few questions? The first thing is, there is from the regulatory bodies, every day they announce the bed vacancy status. Does anybody, do we have any utility of this bed vacancy status that is made available for the public? What does it carry? What meaning does it carry to the public?
So see, that's a bed availability as per this regulatory commission. They have started this one, or the Shastro Bhavan, they have started this your bed regulatory and through website. Yeah. And it's not a very, very exact figure that they are showing, because though it's a real time, but sometimes what is happening, as I told you, there are in the website we are showing that there is a 20 patients got discharged, and there is a vacancy that's showing 20 beds. But now the question is, 20 bed patients are waiting in the emergency. So before we put into this update this your website, the portal, that is the 20 patients getting the bed, and 20 patients are filling up the vacancy. So there is a huge gap actually. That's a bed number it is showing, and the real time the beds availability, that is it's a very, very difficult way to manage actually. That is not the right figure that they are showing. One of the major area also. That's please.
Yeah. Another major area, please go ahead.
Another major area just wanted to highlight also here is that as we are talking about the infrastructural part, the bed availability on, there are two other parts also happening. There is one major area of concern it has become right now, the availability of the medicine. All the previous speakers were talking about remdesivir has been a well-defined drug, and it is really acting to this your critical care patient, but there's a huge shortage of the remdesivir medicine in spite of our all effort, and maybe state government is also trying their best, but that remdesivir is not available in the market right now. There are 100 patients waiting for remdesivir. We are getting only 10 or 15 or 20. So there is and most of the private hospitals, I'm not very sure about the government setup, but the private hospitals, they are having a huge crisis shortage of this your remdesivir. Most of the patients, we have to discontinue the remdesivir. Maybe yesterday they are getting, today they are not getting. Again, tomorrow we'll have to wait for the remdesivir. So that is also one of the major area of concern. And
so the oxygen availability has been taken care of, I believe, right?
Oxygen availability, see, so far Bengal is concerned, we have not faced so far the oxygen crisis as your other states are facing, like your Delhi and all. See, oxygen, that is so far the liquid oxygen is concerned, which is the, that's the running oxygen that is online. That is available so far. That's no issue. But so that's the crisis of this, the cylinder oxygen, where that because the many patients, they are in the home care, they are all using this, cylinder oxygen, portable oxygen. That is a huge crisis so far as well. And but hospitals, we have not yet faced any kind of oxygen issue. The other part also, the oxygen part, that which because getting the message from this your other states, our other colleagues of the other states, so that we could see that what they are facing in Delhi. Some of the hospitals, they were talking about that their oxygen storage is maybe for running to manage the patient, whatever the number of patients in the system, they can manage maybe 1 hour, 2 hours. It's very scary kind of a situation, because there are hundreds of patients in the ventilator. Now there is an ECMO. There's a lot of patients are in ECMO. Now, this situation has happened maybe because of the huge consumption of the oxygen, because these new variants which we are talking about, that's the oxygen consumption also is very high. But we have also started taking daily stock, daily update of the oxygen, because we are also, we'll have to be very careful. So there should not be any wastage of oxygen. And we have started doing a lot of exercise and getting this update of the figures and all. We could see that the last, the January or the February oxygen level, consumption level, or the March, the last year, and this March, this April, compared to this April, this oxygen level consumption has become a double or the triple to some extent. So sudden consumption has gone very high, and the supply is also same supply or restricted supply. Number of patients also increasing. So far, yes, of course, we are not yet faced the liquid oxygen crisis. Tomorrow also, I am having a senior level meeting with your oxygen suppliers, and let's see. We'll be able to understand what is the condition, what is the stability of the oxygen supply.
Another issue was during the first wave, we have seen much stress has been given on the isolation centers. In the second wave, the isolation centers are being neglected. Is it a cause for concern? Isolation centers which has been working in the first phase.
Safe homes.
Yeah, safe homes, stay centers. It is not being stressed right now during the second phase.
Also, many hotels were taken up, in the last phase, as far as I can remember.
Yes, that's why I'm talking about, see, increasing number of beds is not the solution. Whatever number of beds you have, if you are all the private hospitals, they convert to this 100% of the, because now Commission is saying 60% of the bed capacity to be converted to this your COVID bed. But if we are converting the 100% also, that is also insufficient. It is not that you will be able to manage with the number of beds. So only solution is that the patients that coming up with the safe home. Yes, of course, the safe home, as I mentioned you earlier, that the gradual increase of number of cases last year, and this is because they have given some time. So from March to August, gradual increasing, and government has started thinking lot of innovative ways. They started thinking of this year increasing number of safe home or the satellite center. This year suddenly it has happened. Yes, government is now trying. We are also trying to come up with some safe home, like some stadium, some banquet hall, to convert it.
Yeah,
as
it was done during the first phase, but it is not being done right now.
That discussion has started today. Also, I had a discussion with your chief secretary and all. So they are talking about that if you can take the Gitanjali Stadium or some other stadium where you can keep some oxygens and doctors and the nurses, and you can start with the patient managing the COVID patient. Yes, of course, we are just exploring those ideas, and let's see.
Another issue I'd like to take up. During the first wave, there was a hospital specified for the medical doctors. KPC Medical College has been earmarked, and anybody getting infected in the process has been allowed to get admitted there for their own treatment. So in this phase, I think nothing has been done for the medical doctors as of now, right?
Yes. Last year, because that was the first time that we are handling that situation, and many of the doctors, many of the healthcare front workers actually were getting infected. So that was a government decision, because that's the KPC actually is taken up by the government. Actually, that's a requisition by the government, West Bengal government. And that has been identified as that many of the doctors can go there and can get the beds. Of course, that is not there at time. And this time we see that doctors are not, because the doctors also have become very protective. Also, they could know that, yes, what to do, what not to do. So we see that's a very, as of now, we see there is a very less number of doctors getting infected, or even also the healthcare workers as well. Maybe because of this, most of the doctors and the healthcare workers, they have taken this double vaccine, and maybe the intensity is low, severity is low. So someone is getting affected, but home care service is sufficient. That home isolation is sufficient for them. So they are not preferring to get admitted in the hospital. And we also, in our hospital, we give a lot of priority to the hospital. So the doctors. So any doctors, if we see someone is looking for bed, immediately we try to get,
basically that was my next question. So how as a member of a society, how can we request you to such that any of our members in requiring an admission, how do we approach, whom do we approach, where do we approach?
Or family members.
Or our family members, how do we go about? Can you give us a guideline?
See, this we have, no, it's a difficult means, yes, of course, at present, we do not have any single kind of a channel that will be able to handle those patients. But yes, of course, we have a call center, 24/7 call center, that is one. And if you are talking about your members or your
I'm
association,
talking about our association as a whole.
Association members or the family members of the association. Yes, of course, you must be knowing any one of the doctors and administrative staff of the hospital. So maybe that is the only channel that you can take right now. That is the one. But there is no single channel for the doctors and all. So your association doctors, or maybe members, or maybe the family members of the association, you'll have to go through some of the administrative staffs and our hospital doctors. So you must be knowing each and every one. So that is the only way right now.
I have a question, slightly different.
Yes.
In a small township where we stay, about 6,000 inhabitants, 60% of whom are vaccinated for COVID-19. If we plan a safe home for our inhabitants, 6,000 odd people, how many beds should we look into? Like what is the number of beds we should target for a safe home?
That is, I don't have much of an idea about how many beds, but I think 200 to 300 beds will be sufficient as a safe home, or max to max maybe 500. But the question is here, one of the major issue is the human resources, manpower. There is no doctor. So to manage the safe home, to manage the satellite center, because you are dealing with the patient, maybe safe home, maybe satellite center, but that is all the responsibility of the hospitals. Because we have seen, we have a couple of hospitals we have taken, and many of the patients I could see that they require immediate hospitalization. So we'll have to shift the patient from the hotel to the hospital. Now that's the question is, if we go on increasing the number of satellite center and the safe home, and if we do not have the proper kind of bed vacancy in our place, that is also one major concern. Now sometimes we are releasing those our code blue bed also, because that the patient had got crashed, and we'll have to shift the patient immediately. So that's a major concern, is also that managing the safe center, safe home and the satellite centers is the human resources, that is the RMOs particularly, and the nursing staff. Nursing staff, Bengal, we are dependent on the outside nurses. Almost 70 to 75% of the nurses actually comes from the outside. Outside means, yes, earlier we used to get from Kerala. Now we are getting nurses from Jharkhand, Bhubaneswar, and Northeast. Due to this, your pandemic time, and due to this, your air services not very regular and all. we are not getting the nurses as well. Many of the nurses actually they have left because of the crisis. They left to their hometown and they are not returning back. So that's a major crisis is the human resources that RMOs, particularly RMOs and the nurses. Some of the consultants we are managing, they are going to the site, they see the patient, but we need to monitor the patient 24/7 through these RMOs and the nurses. That is also very, that's a severe crisis is there as well. Even we are not in a position to start opening of your new ICU, critical care. We are trying to convert some, because of the demand, we are trying to convert some of our general bed category to ICU. So we are trying to procure this your ventilators and the monitors, but we are getting those ventilators and monitors, but there is no manpower. Even at present, my Dhakuria unit, we are ready with 10 ICU beds, no manpower. We are not in a position to start. We got the material, but we are not in a position to start your ICU. So that's a crisis in terms of your manpower. It's a huge crisis we are facing. Yes, of course, with this crisis, we are managing somehow and we'll have to continue.
We just wish that the Hospital Association of Eastern India should think over like safe homes for healthcare workers as such, because they feel more secured and assured to work with a lot of courage.
So, so for the safe home for the healthcare workers is concerned, each of our hospitals, I'm talking about the healthcare association, if you're talking about, or even in my hospital as well, MRI, we have all safe homes. I mean the guest houses. So at present, maybe across my 3 units, there are almost 30-35 staffs got infected. So they are all in their safe home. I mean, across the 3 units, we are not sending them to home. I mean, their respective home. We are trying to keep them in the safe home, and we are giving all free food, free lodging, everything we are giving, and we are keeping them comfortably in a guest house, nice guest house, and that we have already in place.
That's great.
I have a quick question. If as the situation is arising, people are waiting for few days for RT-PCRs. So will the hospital be in a position in near future to start admitting patient and treat them on the basis of the rapid antigen test, or they have to wait for RT-PCR test?
I think as of today, government has not yet approved this your rapid antigen test for the private healthcare. So this is only the way out is the RT-PCR. See, the RT-PCR and the CBNAT, this 2 part. Now, for the inpatient, the patient those who are coming to get coming to our hospital to get admit. So we are doing we are taking this TrueNet or GeneXpert so that the process can be a little bit faster. But major of the patients in the OPD and the general public, we are talking about the RT-PCR. So RT-PCR as of now, it is the only way to detect. Because government has not yet given permission for rapid antigen test. So let's see how the government starts. There is a crisis also of the your RT-PCR, that is also a big crisis. Now, earlier we used to give report in 24 hours time. Now it is being 48 hours, 72 hours. That's very difficult. 72 hours, the patient will have to wait for a COVID positive test to confirm. And then till then he's moving around. So that is as very difficult. So we are trying to increase our infrastructure part. That is, and we are trying to take this RT-PCR from, as of now, we are doing around 400 to 500. Now we are trying to make it to 1,000. That planning we are making.
Sir, I have a question. If I'm allowed to ask, Devashish,
Yes,
can I ask a question?
Yeah,
Yes, sir.
please.
Yeah, I'm Dr. Sudipta Mitra. Good evening, Mr. Rupak
Good
Porava.
evening.
Yeah.
Good evening.
I just wanted to know is, as I've just heard, that from the government guidelines, that RT-PCR kits are also getting limited because now number of cases have increased. So is there any guideline from the government issued that you should only test symptomatic patients and not suspects who are just going in? Earlier, as it was happening, many people were just walking in to find out if their RT-PCR is positive or not, just even without symptoms. So So is there any guideline right now with you?
There is no, as such, there is no guideline, but the guideline is only we'll have to use this RT-PCR in a very, very right patients. Means the patient is really is asymptomatic and all, we should go for RT-PCR, because RT-PCR is a very crisis. As I told you, the reagents are not available in the market and a sudden increase of the number of cases. So we request that the patient those who doesn't need RT-PCR or unnecessarily, they should not go for testing unnecessarily. They should be at home. But those is really, there is some symptom, they should go for RT-PCR. Yes, government also in every discussion, every our interactive session, they talk about that we should use RT-PCR in a very, very restricted way, so that unnecessarily we should not waste that RT-PCR. Anybody should not come out. That is now one part also that has been increased about RT-PCR is concerned, the COVID test, because those are travelers. Because now almost all the international flight, they need this your positive negative report, and this your even some of the states, they are not allowing the travelers to travel without the RT-PCR. So that is also one area where it's in consumption has increased, number has increased as well.
And the
one more question, just if you can take it.
Second. The problem there, most of the flights are taking reports which are not older than 48 hours. The reports are coming even after 3 to 4 days. Some of the places are taking
72 hours.
As the vice
72 hours. 72 hours.
72 hours. It's very. So yes, of course, that is also a big area. I mean, those who are giving the sample on first day and the report they are getting almost the day of departure, and sometimes they have reached airport and they are calling from there. I have not yet received the report. Please send the report. So that's a yes, of course, it's a different way. It's a crisis, many ways.
Yes.
Yes, sir, as you said that there were a lot of patients who were coming in who were waiting for planned surgeries, etc. So now the crisis is so acute that COVID beds had to be increased, all manpower is pulled into it. So, sir, what is your planning right now about the planned elective surgeries, I would say?
Planned elective surgeries has been banned for 2 weeks.
No, I just want to know sir's opinion, because that circular was not really sent to all hospitals. Debashis, this is I must say
it is Calcutta Medical Calcutta.
No, not even the Calcutta area, KMC area also. All hospitals did not receive all this circular. That is why I'm asking
also,
Mr. Rupak Bureau if he can tell us.
It does not suffice that the agenda is not there. The agenda is there.
No,
they have received it or not.
That notice is not there in their website.
Not there. It is not there in the website. So, is there any information with Mr. Bodua?
Yes. I tell you. So during our last health committee meeting with the chief secretary and the commission chairman, all. So they have requested, yes, of course, that is not written, but they have verbally they have told us just to stop and reduce number of planned surgery. Because of this two part, one is the planned surgery. One part is that so that we can equally the dose number we can convert to COVID beds. So there is the less number of non-COVID patients in the system, and those beds we can utilize for the COVID bed, because that's more urgent. Planned surgery can wait for some time. And the other part also, there is an oxygen consumption as well. If you see, there is one lap chole surgery needs a huge kind of an oxygen, and that also we can save and we can utilize for the next patient, for the COVID patient. So as much as possible, we have also restricted all our private hospital, across private hospitals, we have restricted planned surgery. One way, and the other way also, many of the patients also, they are not willing to come for surgery right now. So it has happened because initially what we have seen 7-10 days before, still the patients were willing to go for surgery, but right now patients are not willing to go for surgery. That is one part. And of course, government has given a verbal instruction to all of us that you should restrict as much as possible the planned surgery, and that we have already started doing it.
Sir, so in short, what I understand is this is mainly to pull in more COVID beds and restrict loss of oxygen through planned surgeries. So in cases where this is not really the case, because it is usually daycare. So my concern is more of my own subject naturally.
Sudipta, I have to interrupt you. Why are you thinking of planned surgeries now?
No, I'm not thinking of. I just want the guideline. I just want the
There is no
guideline.
guide, Sudipta. You have to wait. This is not the time for this discussion. It's an situation. We should not think about this now.
I think we should not talk about the planned surgery right now.
We should not talk about it now. Cataracts
it is not the right time. It's not the right time.
It's for your own security also. You don't do like this.
Exactly.
My opinion.
Yeah, of course.
Both for the doctor and the patient as well.
Okay, is there any more questions from any of the panelists?
I think Dr. Rajesh Chaudhary has a question. Rajesh, you are muted. Rajesh?
Yeah. Mr. Borua, very nice presentation, and I know what a signal role you have played in leading the AMRI group. My question is, I'm concerned that with all the news we hear about the short supply of oxygen, people have already started hoarding oxygen cylinders.
Yes.
I know that for sure because in my neighborhood, I find people are, renting out oxygen cylinders or buying oxygen cylinders. And I think this will have a domino effect eventually in a total oxygen supply. Maybe not for a hospital like yours where you use a centralized system, but for smaller hospitals, smaller nursing homes who rely on cylinders, they'll have a problem. And how to prevent that actually?
See, this is, yes, of course, this is a very rightly you have pointed out that many people actually, they are storing the oxygen just because they may be just to avoid some of the crises. And we have already raised this issue during our healthcare meeting as well to the government. And the government is trying to take action. And I think it is in the district level, particularly, the police is also working it out. Any kind of a complaint they get, they are taking action. Because of the pharmacy, you must have seen from the media that the pharmacy, they are showing there is no oxygen, but from the backside, they are selling oxygen. So what it happens usually because when there is a demand and supply gap, that is happened. So immediate step has to be taken and this part. And if you are talking about central oxygen supply and the cylinders oxygen, but ultimately the oxygen, that is the production. Production is limited. You can't increase production 3 times, 4 times, 10 times overnight because we have very limited plant. And there is we have heard that they are stopping this supply to industrial belt, and mostly the government instruction is that only to healthcare facilities oxygen should go. So the government is taking some action, but yes, of course, this is happening, and we'll have to avoid this for our future betterment.
Thank you. Thank you very much. There is a question for Anjan, Dr. Anjan Mukherjee. If I can repeat the question for Dr. Anjan Mukherjee, I'll keep Mr. Borua on wait for a few seconds because Anjan has just logged in. How long does the immunity last after the...
I am there, sir. Hello?
Yes, Anjan. How long does the immunity last after the second dose of vaccine? And
this is a very tricky question to answer. Because we
you are not audible, Anjan. Dr. Anjan, you are not audible.
Then I think the net connection is...
Yes. So go on, Devash.
Subodha, I think it has been answered previously. Yeah. No one knows. There is no data to say that as of now.
No one knows.
Yeah. Okay.
I have a very simple and general question. How long can the home isolation go on? I mean, the patient is worsening, so how long should he wait? I mean,
if the patient is worsening, he has to be shifted to the hospital. And if he is gradually improving, then for 2 weeks.
There is no bed. So what to do in that scenario?
So it has just I give some of the our figure.
What can we do?
See, some of the latest what is happening in the home isolation. People are staying in the home isolation, and they are continuing, as you are talking about, when they should take a decision that they should shift to the hospital. That is not well defined. And in return, what is happening? Suddenly they feel that this oxygen level has gone down to 70, 70, 65, 70, and they are rushing to the hospital and they are looking for a critical care ICU support, which is not there. That is the major part actually. If you see the death part, death issue is also happening because the monitoring part in the home isolation, they are, you know, that home isolation, how you'll be able to monitor. Just they are supporting with the oxygen, 5 liters, 7 liters oxygen they are giving. And suddenly they could see that is that they are not in a position to manage. They are rushing to the hospital, nearest hospital or whatever. And maybe there are a couple of beds available in terms of your general bed, what category, but there is no critical care, no ICU, no ICU. So there is a big gap actually. So you had the right question actually, but that is not well defined when you should go. But yes, of course, if I'm not a technical person, but still I should whatever I see day-to-day basis. That is, if it is below 90 oxygen and it is in spite of you increasing the oxygen support, you are not in a position to manage. Better to rush to the hospital.
Okay, there is a question from Dr. Anshuman Mukherjee. Mr. Boru, how often you are seeing the kids getting affected and getting admitted to the hospital? In what is the scenario in Amri? Kids getting COVID and getting admitted.
Exactly what you're asking is getting affected.
No,
and
he is
getting
asking what percentage of children are being affected by the virus. Children.
Yes, of course, we are getting some. I mean, figure out of that statistics is showing that is the children are all getting affected, but not that many number. Not many number we could see. Yes, of course, earlier during the first wave that we didn't experience this kind of a scenario of the pediatric patient. Yes, this time we could see that your number is, there are numbers, there are the children are getting affected 5 years, 3 years, 7 years, but not that many number. Not many number we can see in our emergency patients are waiting to get admitted.
I think Dr. Sumon Kanungo has shown in his slides the difference is not much compared to the first wave. It's not statistically significant. Yeah, we have come to a conclusion.
Yes, thank you, Mr. Borua. Thank you very much for sharing your very valuable Sunday evening. This is probably the only half day you can spare for your family, and you have spared that time for Ophthalmological Society of West Bengal. So we are very grateful to you. Thank you so much.
Thank you.
And you have led Amri to a greater height, and I am proud to be an Amri doctor. So is Dr. Sudipta Mitra as well. And may I request Dr. Sudipta Mitra now to give the vote of thanks. Sudipta, please.
Yeah, thank you, Shugato. Yeah, this was a very nice evening, a very enjoyable evening, encouraging evening, relieved and relaxed by a lot of informations from our speakers who have been with us today, from other faculty, Mr. Rupak Borua, who has come with the logistic information, and all the doctors, Dr. Anjan Mukherjee, Dr. Shamashish, and Dr. Shibo Priyo Banerjee. So I would like to thank our chairpersons, Dr. Pushpita Shahu, Dr. Kajal Prasad Ghosh. I would like to thank our esteemed panelists who were with us, and the discussions were brought out very important points in this evening. And dealing with the situation of COVID is really dreadful situation that we are facing right now with the second wave of COVID. And I am very sure all staying together and with all the information that we gathered, we will have many other questions, and I'm sure our speakers will be there with us again to help us tide over this crisis. I thank you all. Dinner must be waiting. We are a little bit late today evening. So see you all safe again in some other platform. On behalf of Ophthalmological Society of West Bengal, I wish you all a very good and healthy and safe future ahead, days ahead. Thank you and good night.
Thank you, Sudipta. Pushpita Di and Kayulda, do you want to add anything more?
Sorry.
We are really enriched and we are grateful to all the speakers for helping the Ophthalmological Society to learn the whole situation. Thank you all. Nothing more to add.
Dr. Ghosh. Dr. Ghosh,
Can I
President
say
of
something?
Yeah. Yes.
Right. I was keeping quiet all this time listening. And what I really felt was that the title itself told me two things. Number one, all of us were expecting a second wave. Number two, most of us felt that because we have weathered the first wave so well, we are experienced enough to deal with the second wave. And all this reminds me that there has been a thread of complacency running through the whole event, starting from the individual doctors to each layer of the society right up to the top. And it is this complacency that we have accepted is the reason why we are facing a problem now. And we once again face a situation which we are not prepared for, we cannot tackle. And even now we are talking about emergency surgeries. We are talking about whether we should do non-emergency surgeries. So I think basically all of us, every citizen of this vast country should start to be more responsible, to be more sincere and dedicated to not only improve and safeguard ourselves, but to safeguard all those around us. And only in that way can we, in the long run, become truly victorious. So we have to prepare. It's no point only blaming, the government or blaming this one and that one. We should start from scratch. That is what I feel. So the complacency has to go if you want to win. Thank you.
Thank you so much for the valuable input. And at the end of the day, we should all remember that we have to maintain the protocol of wearing masks, maintaining safe distance and hand hygiene in spite of getting double vaccination. It is a must for each and everyone. The protocol should be followed. And at the end, I would like to thank Ocularis Mankind for coming ahead and sponsoring this event. Thank you so much. Mr. Aditya Agarwal is here. If you want to add anything more, and I hope Ocular Mankind will be there again with this sort of program to enrich the ophthalmologist. Aditya, if you want to add anything before we end the meeting.
Thank you so much, sir, for the event. That's it, sir. Thank you.
Thank you. So
have a great evening, sir.
Thank you so much. So I thank each and everyone for your participation and sparing your time. So can we end the meeting?